Welcome everyone to the Malaria Partners International webinar series and today's event, Malaria and Gender Equity. We're really excited to bring this event to you today. We have a great panelist of speakers from different organizations to talk about this topic that has been of interest among our group and our audience. And we hope by the end of this webinar that we answer the question, what is the connection between malaria and gender equity? My name is Ariel Delaney, Deputy Director with Malaria Partners International, formerly Rotarian Malaria Partners. This webinar is part of our ongoing webinar series, which aims to engage Rotarians and the malaria prevention community on unique topics of interest made accessible to everyone. The mission of Malaria Partners International is to engage Rotarians worldwide in the fight to eliminate malaria. Our moderator for today's event is Marcia Mutisi, board member of Malaria Partners International. Marcia is an accomplished leader who applies her collaborative skills in mobilizing actions and resources for working groups and service organizations such as the Washington Global Health Alliance, where she's a board member, and various immigrant communities in the Pacific Northwest. Marcia is currently a senior solution manager at Microsoft. Her prior professional background focused on management consulting for Accenture for Microsoft, as well as Nordstrom and several other companies of the Pacific Northwest. She holds a degree in business administration. She also brings a unique perspective and background to today's topic, which she'll share with you shortly. I'll now hand over to Marcia, who will begin with introductory remarks and then introduce our speakers for today's event. Thank you.
Thank you, Ariel. I wanted to add to that introduction that I was born and spent my early years in Zimbabwe. And as we all know, sub-Saharan Africa is where malaria is most prevalent. So I'm very happy to be here. I'm also a mother, so this is a topic that's very near and dear to my heart, and all my family's back in Zimbabwe. I'm also a long-time Rotarian, so in fact, a lifelong Rotarian, I consider myself. Malaria Partners International is honored to present today's webinar. In addition to its Rotary advocacy work, MPI is in various stages of training and equipping over 1,700 community health workers in Zambia and Uganda. In conjunction with their respective ministries of health, Malaria Partners is also supporting malaria public education in the Gambia, indoor residual spraying in Ghana, among other efforts. Today's webinar is entitled Malaria and Gender Equity. Many may be thinking, what does gender equity have to do with malaria? Most notably, malaria and gender equality are interconnected through Sustainable Development Goals 3 and 5. We know from the most recent World Malaria Report that pregnant women are 3 times more likely to get malaria. The connection between gender equality and malaria is relevant in a number of ways. To better understand them, we have to understand the role of women in the community. Often, women are solely responsible for caring for children. When children are sick with malaria, women stay home from work and school to care for them. Women are also oftentimes outside during times when malaria carrying mosquitoes are most active, doing agriculture-related tasks, cooking and fetching water. Access to affordable and quality healthcare is a barrier to care for many women who are impacted by poverty. For girls, reducing malaria rates could lead to an increase in education and literacy rates. Though women face a variety of barriers to gender equality, by eliminating the risk of malaria, women can be more empowered and enabled. Our speakers today will touch on much of what I spoke of and more. I'll introduce each speaker individually, followed by their opening remarks. Our panelists, Sagri Singh, who is a senior advisor of gender equality and development at Unicef. She provides strategic management and technical guidance on gender responsive programming to achieve results for women and children. Sagri guides the implementation of UNICEF's Gender Action Plan as it relates to promoting gender equality in health, HIV, nutrition, and education outcomes for children, as well as adolescent girls, empowerment, and well-being, specifically in the areas of health, HIV, nutrition, ending child marriage, and secondary education and skills, and the intersections between them. Sagri has over 25 years of experience in designing and conducting research programs, and advocacy initiatives on sexual, reproductive health and rights, including HIV, in South Asia and East and Southern Africa. She has worked in multiple country settings, including building capacity and leading multidisciplinary work on program research and policy strategies. Her prior experience includes working at the International AIDS Vaccine Initiative, World Health Organization, the Gates Institute of Population and Reproductive Health at Johns Hopkins University, the Population Council, the Ford Foundation, and the International Women's Health Coalition. Sagri received her doctorate in public health from Johns Hopkins Bloomberg School of Public Health and her master's in international health from the Harvard T.H. Chan School of Public Health. Thank you, Sagri, for joining our panel today.
Thank you, Marsha, and thank you for the opportunity to be part of this panel to contribute to the discussion on the role of gender in malaria prevention efforts. Promoting gender equality and empowerment of women and girls is central to UNICEF's mandate and a core component of our focus on equity. And because power structures in societies across the world mostly privilege boys and men, advancing gender equality most often requires addressing disproportionate advantages and the discrimination faced by girls and women. Marsha has already alluded to this in her opening point. At the same time, we acknowledge that gender inequality does pervade all aspects of life, from the personal to the family, social relationships, institutions, and affects not only women and girls, but also has a detrimental impact on men and boys. And in order to promote gender equality and achieve equity, we really need to think about engaging all sexes and genders to make progress toward justice and equality. So in terms of today's conversation, if we look at inequitable gender norms, they place harmful and unfair burdens on girls. For example, they're more likely to be taken out of school compared to their brothers or boys in their family to take care of sick relatives. And yet we know that girls' education is not only critical to increasing both her economic and personal empowerment, but also contributing to family and community income and prosperity. We also know that gender equality and education is one of the key factors in reducing child mortality. Because women and girls are more likely to see a doctor if they're educated, know where to access the appropriate information in a timely manner, advocate for their rights, and to protect themselves and their children, including against malaria, which can be a deadly disease and is preventable. So combating gender inequity will thus be essential in fighting and overcoming a preventable disease such as malaria. And I look forward to promoting some points regarding how we can address gender equity and malaria based on other sectors. Thank you so much.
Thank you, Sagri. Next, we have Valentina Bull, Global Malaria and Health Partnership Advisor at UNICEF. Valentina has worked to assist countries to continue scaling up integrated malaria interventions and works to foster greater harmonization among global malaria initiatives. Much of her time working in malaria endemic countries, such as Democratic Republic of Congo, Angola, Kenya, Madagascar, Cameroon, and Mozambique, where she supports countries in the development and implementation of UNICEF's Global Fund grants for malaria, as well as with coordination and distribution of long-lasting insecticide nets, antimalarials, malaria diagnostics, intermittent preventive treatment during pregnancy, seasonal malaria chemoprophylaxis, integrated community case management, and the development of supportive community and health systems. Valentina has also worked for the World Health Organization's Global Malaria Program, the International Rescue Committee, the International Organization for Migration, and the United Nations Development Program. She holds a master's degree in public health focused on malaria control in refuge populations, as well as master's degree in international affairs focused on economic and political development and refugee law, both from Columbia University. She's working toward a Doctor of Philosophy in Epidemiology at the Swiss Tropical and Public Health Institute, focused on improved delivery of malaria interventions in difficult contexts. Thank you, Valentina, for joining our panel today.
Thank you, Marcia, and it's nice to be invited back to this wonderful webinar series. To complement Sagri's opening remarks, we do know that women and children, particularly girl children, are the most vulnerable to malaria. However, as Sagri mentioned, they are often the least able to access effective interventions. Studies have shown that as women's access to financial resources and decision-making power decrease, so does their ability to exercise treatment-seeking behavior for children with malaria and for themselves. The World Malaria Report for 2020, which was released late last year, showed that in 2019, there were 229 million cases of this preventable and curable disease. We know that tragically, 2/3 of the lives lost were children under 5 years of age. We also know that in 33 moderate to high transmission countries alone, 12 million women were infected with malaria during pregnancy, resulting in an estimated 822,000 children with low birth weight. As the COVID-19 pandemic continues to disrupt malaria prevention and treatment programs, while also producing devastating setbacks to women's and girls' health, education, and safety, it is more important than ever to recognize the significant role that gender plays in malaria morbidity. I look forward to continuing to contribute to this panel and to have more discussions on how gender plays a role in malaria. Thank you.
Thank you, Valentina. Next, we have Olivia Ongoo on our panel, and she is the founder and executive director of Impact Sante Afrique, an African-based NGO. Prior to launching ISA, she worked for 10 years for Malaria No More, where she led the Cameroon and African programs, helping to keep malaria high on the agenda and rally political, celebrity, private sector, and community leaders around the cause. Olivia began her experience on malaria as the special envoy for malaria at the United Nations. During that time, she taught a public health course at the City University of New York. Health of the Wellness Project for undergraduate students at City College. She also worked with the New York City Department of Health and Mental Hygiene Bureau of HIV/AIDS Prevention and Control as a research assistant. And she was a fellow of the Harvard University Science of Eradication Malaria Leadership course. She holds a master's degree in public health. Olivia has a great passion for public health and the fight against malaria and maternal and child health. She is striving to make humble contribution to help create a world where no child dies from a mosquito bite. This is something I share in common with Olivia. She is committed to ensuring communities are included in malaria and health programs as equal partners. She recently elaborated a guide on community issues, social rights, and gender in malaria programs, and tool for malaria civil society to increase participating in global fund mechanisms. She co-founded and established the first global network of civil society for malaria elimination, which she now coordinates with more than 300 members from 43 countries. Thank you for joining us today, Olivia.
Yes, thank you very much for having me. I'm very fortunate to be among a panel of such a great leader in the malaria fight. So I want to thank the organizer for hosting this meeting, because it's very important that we start having real conversations and meaningful discussions around how gender affects malaria, specifically in terms of access of malaria services for the most vulnerable population. And we know that, unfortunately, women and children pay the highest price and are the most affected by malaria. So having this discussion and this talk today around how gender affects malaria programs, it's a good step on how we're going to strategize together as a global community to reduce the burden of malaria and to save life in malaria-affected countries. Thank you.
Thank you for being here today. And next, I would like to introduce Jessica Rockwood, who is the president of International Public Health Advisors. Jessica has over 20 years of professional experience working at the intersection of international development and business. Consulting services have been provided to roll back malaria, UNDESA, the World Bank, United Nations Foundation, the Global Fund, and corporate clients in sectors including public health, transportation, and energy. She has extensive experience in Africa development awareness campaigns, public policies, and funding mechanisms to prevent malaria and other infectious diseases, such as HIV/AIDS. Mrs. Rockwood has particular expertise in the funding, procurement, and partnership practices of donor agencies, including conducting evaluations to measure results and developing toolkits to improve adherence to guidelines. Thank you, Jessica, for joining our panel.
Well, thank you very much. I'm very happy to be here, and I'd like to thank the organizers from MPI for having me speak today. My opening remarks are going to be a little different based on some of the work that we've undertaken in addressing human rights, gender-related barriers, and strengthening community engagement in Global Fund malaria grants. Beginning in 2016, the Global Fund Community Rights and Gender Department began a process of identifying barriers that deprive at-risk populations from accessing and receiving malaria commodities and services due to a number of reasons, which include gender inequalities, financial barriers, social exclusion, cultural norms, and others such as complex emergencies. My organization, IPHA, has worked with the Global Fund, the RBM Partnership, and CSO partners to assess which populations were more impacted and underserved. It's through this engagement that the pre-piloted version of the Malaria Matchbox was developed. The Matchbox, as we call it, is an equity assessment tool to improve the effectiveness of malaria programs, and that can be found on the RBM Partnership website. I'd like to note that beyond pregnant women and children under 5, populations also include those considered high risk, such as non-immune groups, mobile populations, and travelers, but also underserved populations, such as IDPs and refugees, hard-to-reach populations, women and children from poor settings, undocumented workers, indigenous populations, and ethnic minorities. Based on the engagement with countries and requirement to define human rights, gender, and age-related barriers and inequities in access to services in country funding requests for Global Fund, it became clear that many countries required assistance in identifying populations and services needed for all at-risk groups beyond pregnant women and children under 5. We have provided that technical assistance through the RBM CRSPC mock technical review panels over the last 2 funding cycles. And while now it's being streamlined, this is still a relatively new way of thinking for national programs. As recently as 2020, the TRP noted, and that's the Global Fund Technical Review Panel, noted that they are still receiving a number of gender-blind funding requests with limited attention to the gendered dimensions of malaria in particular. So based on their reviews beginning in 2017, and as I said, through 2020, the TRP is recommending that applicants assess technical assistance to translate analysis into solid programming based on contextually grounded evidence about inequalities in access to services. The Malaria Matchbox is one tool that can be used to assist those countries. Thank you.
Thank you, Jessica. I'd like to follow up with a few questions for each of our panelists, starting with Valentina. What role does gender play when it comes to communities' vulnerability to malaria?
Thank you, Marcia. So I'd like to divide the question into 2. As was very aptly illustrated by Jessica, we have a number of factors on how communities and how gender affects their risk of contracting malaria. The first is biological. So as we know, only women can become pregnant. And during pregnancy, immunity is reduced, making them far more vulnerable to malaria. Unfortunately, malaria during pregnancy affects not only women, but also their unborn children. And even when the children are born, if they are low birth weight, they will have concomitant and lifelong effects. Another biological issue is malnutrition. Unfortunately, women and children are often far more at risk of being malnourished, which also puts them at much higher risk of contracting malaria. As Jessica also illustrated in her table, there are a number of socioeconomic factors which put communities at risk. The first is poverty. We do know that poor populations, especially poor women and children, are those who are at risk. They have lower access to treatment, they have lower access to services, they have worse housing, which again puts them at much higher risk. Stigma is also associated with many sociocultural factors which do not allow them to seek treatment. So women will often not be allowed to seek treatment from a male community health worker. They may not be allowed to travel. They may not be allowed to leave the home without a male's permission, which again puts them at much higher risk of not being able to seek treatment for themselves or for their children. Work distribution also affects women, but also affects men. We have seen that occupational hazards for men who have to go out into forests or who have to go out into poor housing or working at night or will go into forests, especially in Southeast Asia, again puts them at much higher risk. Women, of course, who will get up early in the morning to work also are at risk of being bitten for malaria. All of these factors, and as Sagri said in her opening remarks, puts a gender perspective on the risk for malaria. Thank you.
Thank you, Valentina. My next question is for Sagri. Sagri, from your experience in supporting gender programming in various of UNICEF's programs around the world, why is it so important to focus on this issue, and what lessons would you recommend for the malaria community?
Thank you, Marsha. I'd like to build on what Valentina spoke about, really starting with the fundamental that gender is a social construct, and as a social construct, ascribes roles and responsibilities in a given society, conferring resources, power, authority, and control to men over women. And this underlying gender construct pervades all aspects, all dimensions of our lives. So whether you are poor, whether you come from an indigenous community, for the most part, we could say that gender really plays a role in the differentiated experiences that men and women, boys and girls might have, as well as those that ascribe as other genders. So social, economic, and biological determinants and consequences of health that we are so focused on are impacted, in fact, by these gender norms, gender stereotypes, gender relationships that result in differential outcomes and require differential approaches if better health and well-being for all is to be achieved. This is why applying a gender lens at the outset of any program, any policy, and having investments particularly focused on understanding how these differentiated approaches need to be addressed becomes critical in a malaria program. I won't delve too much detail into things colleagues have already spoken about the fact that when you have social and economic factors that result in unequal gender norms, limiting women and girls' access to decision making, their access to asset building, to economic empowerment, all of these factors then obviously play a role on their ability to access information in a timely manner, be able to advocate for their rights when they could get to health services, issues of mobility, safety, and of course the burden that's placed on them by having both household chores and potentially productive work ends up playing a role in limiting their ability to get the maximum quality care. On the flip side, from a systems perspective, we know that community health workers, 70% of whom globally are women, also are impacted by these gender inequalities that then might impact their training, their ability to advance in their professional growth, as well as their interactions with other women. And I'm not going to dwell on the biological factors that Valentina spoke about, but these points become important. I just wanted to give some examples. When we look at maternal health outcomes, these are directly related to women's lack of access to resources and information. It's due to poor education access, early marriage, low earning opportunities. And health services that are of poor quality also tend to reflect the low value that is placed on women's health and education. And often women themselves are disrespected by health providers due to this idea of women's issues not being so important. So we really need to consider all of these factors if we have to address how to best prevent malaria within the ecosystem in which women and men, girls and boys exist. We also know that gender inequality is associated with high rates of nutrition and stunting, And in fact, in 56 African countries, there was a strong connection between high levels of undernutrition in adult women and high levels of undernutrition in children. And I just want to make a final point around COVID-19. I mean, nowhere have we had this opportunity to see the impact, the devastating impact of gender implications on the COVID experience that men and women have faced. Biologically, men have higher rates of mortality associated with other diseases, but women have had a tremendous but there's been a tremendous impact on women and men, women's health and girls' health that's disproportionately related to the social and economic conditions that they face. Increased cases of domestic violence, increased burden of household chores, increased issues around health and well-being that's not been able to address it with the health system. So in just ending, I'd like to say, in order to address and overcome disease such as malaria that is preventable, the community must intentionally and systematically consider gender dimensions, identify how best to serve those most affected equitably. This involves a gender analysis at the get-go, gender and sex disaggregated data, gender expertise applied at the beginning of all programs, and most importantly, as others have pointed out, the active engagement of community, institutions, and government, specifically women and girls, in identifying solutions for change. Thank you.
Thank you. Thank you, Sagri. And that takes us right into the next question, which you've already started to answer, actually. But Jessica, if you can delve more into how malaria prevention programs can be designed to take into account the unique needs of women and the barriers to care that they face.
Thank you very much. And indeed, the answer that you all just heard was very succinct and led into this question. I think every country is different. You know, as malaria programs, they do know that their specific focus is on women and children under 5. However, when we look, in my opinion, at universal coverage, which is defined at about 80%, that means you're missing 20%. So you need to really understand, where are those communities? Who are in those communities? What are the access to services? What are the barriers to services? Excuse me. And then look at how to address them. How do you strengthen communities to ensure that they have the voice to be able to have those programmatic interventions delivered in the areas that they need them most? We have done, and Olivia can speak to this, there has been some work done in this in India, Nigeria, and Niger, looking at various types of barriers to all populations and how to address them. But I think that the communities really do need to be more engaged. Thank you.
Thank you, Jessica. So Olivia, the next question will be to you. How does your organization work to change beliefs and attitudes shaped by inequitable gender norms within communities while maintaining respect for local customs?
Yes, so like Jessica just mentioned, we were fortunate to support the pilot of this new innovative tool called the Malaria Matchbox in Niger and in Nigeria. And this tool was very useful because it helped to collect evidence and data and to be able to share them with national stakeholders and in order to actually bring out some of the issues that women and men and others face in community in terms of access to malaria services. So using this tool to collect this evidence and data allow us to produce evidence-based report, and it was much more easier to convince the national stakeholder to develop a national action plan to address some of the issues related to gender. So Valentina and Dr. Sagri also spoke about all of these issues. Stigma, the fact that in Niger or in Nigeria and in many countries in Africa, in some communities, women have a very difficult time to receive community health workers men into their homes when their husbands are not in place. So that actually prevent them to have access to some of the essential services. And we also saw that some women some pregnant women who wanted to use a mosquito net at night were actually stopped by their husband who probably didn't want to use those nets. So they are in difficult. So we have seen different situations based on different countries, based on different groups, based on different communities. But it was actually very interesting to have those evidence and to say this is why we need differentiated approaches. This is why we really need our malaria strategies and programs to be tailored to our social context, to our behavioral context, to our culture, to our tradition, and to take into account the way our community lives and actually how we can make sure that malaria services actually reach those communities. So there were several other issues about languages that were also found, and like Valentina and others says, about just the styles of these communities, the way of living of these communities that actually need to be taken into account when the country develop malaria strategies, and making sure that it's not a one size fits all, but really have specific programs that are tailored to those communities and that can facilitate access to services for those populations. So with my organization, what we do, we build capacity, we aim and we work with experts like Jessica, Valentina, Dr. Sagri and others to build capacity of civil society organizations around these issues, around malaria and gender, around equity, around social and human rights, because we are not talking enough about human rights in malaria programs, which we should, because like Jessica said, we still have a large percentage of the population who still don't have access to the basic tools for malaria, which exist because we can prevent and we can treat malaria. So there's no reason why we still have 20% or more of the communities who don't have access to those services. So we build capacity of civil society organizations around these issues, and we also develop tools for advocacy and communications so that civil society organizations are able to bring those evidence to decision makers and to demand change in policy and change of strategy. And then finally, we have just started this, but we are going to reinforce capacity of communities and civil society organizations on monitoring and evaluation of malaria intervention at the community level to make sure we can raise all the issues around and all the barriers around access to services for communities, and that these can be used for decision making and change so that we can have more communities that are fully integrated and fully included in the malaria programs.
Thank you. Next question will go to Valentina. And we already had a whole webinar on this, which I encourage our attendees to look up. But Valentina, if you can address how COVID-19 has impacted malaria programming, and I know it's been brought up a few times in this discussion, but around the world, and how can we build back better?
Thanks for that. So yes, it was a whole webinar series, and there's now a whole series of documentation and a whole chapter in the World Malaria Report on how COVID has impacted malaria programming, especially at the beginning where we had lockdowns and we had an inability to access treatment. And so I would say that one of the most important lessons learned coming out of COVID-19 is how can we build health systems and how can we do better programming? This will, of course, impact malaria in a very important way as we move into an era of really focusing on universal health coverage and primary health care as an entry point, which will benefit malaria. I think one of the most important lessons coming out of COVID-19 is how much we rely on women. As Sagri said, we have 70% of the workforce is at the community, 70% of community health workers are women. And we saw that as communities could no longer travel to health facilities, they started relying more and more on their community health workers. They had to rely on those who were proximal to them. That will behoove us to then think about as we build back better, as we go back into ensuring that unimmunized children and populations that were unable to receive the essential services that they need, including for malaria, that as we look at these pockets of communities and populations who have not received services during COVID-19, that we have an opportunity to bring integrated services so we can help address malnutrition, we can help address malaria, and we can help address gender inequalities as we build back better. One of these important areas will, of course, be the integrated programming leveraging immunization, nutrition, and gender-based programming to fight malaria.
Thank you. And again, the next question is also building on that topic of integrated programs and services. Sagri, can you tell us some of the practices you have seen that can improve gender equity and how these can be integrated into malaria programs? So if you can just expand on that.
Yes, thanks so much, Marsha. And really building on that, for transformative change to occur, we really have to start to address women and girls' positions and not just their conditions. And so we see, as Valentina rightly pointed out, really using gender data to be able to understand what are the multiple deprivations that girls and women face and how best to identify pathways of change that will impact them directly. Examples from child marriage programs in particular are very useful because what they show us is that while child marriage sits squarely within a child protection sector of expertise and speaks to violence, really adolescent girls' reduction in child marriages is largely attributed to programs that speak to providing cash transfers, keeping them in school, and making sure they have access to learning. So as you can see that while child marriage is in one sector, we find that the most effective interventions might be in other sectors. So having the proper gender analysis and data to be able to identify where those opportunities and entry points might be are very meaningful and might be considered for the malaria program as well. We have the similar issue around reducing HIV acquisition among adolescent girls. This is the subgroup with the highest number of infections. And we do notice that beyond the behavioral and biological interventions, really looking at how girls' economic and personal empowerment programs are benefiting them, whether it's through education, whether it's through cash transfers, whether it's through in-kind asset building will be really critical. A second point is building on what others have spoken about is really promoting women and girls' rights as a key component in creating spaces and opportunities for them in leadership positions, as well as in participating directly in identifying problems and solutions that are best suited for their communities and their environment. And doing this in an active and intentional way, making sure that girls and women have a collective space to be able to advocate for what they need is very critical. And we see, for example, in the work around community health workers, that women who are in positions of power, as supervisors, for instance, the community health workers that work with them really sort of report having much better training, motivation, feeling valued, and actually resulting in them being able to handle their work in a more culturally appropriate way. The last point, just the third point on this is for transformative change, we know that gender is a relational issue and there is definitely a power imbalance. And what we've learned from our experiences and other work that we've done as UNICEF is that we need to provide alternatives to gender roles and norms such that we engage women and men as much as possible as equal partners in solutions and think about how we can promote or facilitate the redistribution of roles, particularly around childcare, such as creating spaces where men feel engaged, deploying male role models to communities, encouraging couple communication. We know this is really critical because while the decision making is happening with the men, the targeting of interventions is with women, and it really becomes important to facilitate that dialogue. And finally, also encouraging men to participate in multiple reproductive health and other health outcomes. So I just wanted to stop there with those 3 points, saying that, certainly malaria programs can learn from these examples. There are a lot of programs that are probably already applying these approaches. It would be great to learn from those experiences. Thank you.
Thank you, Sagri. So thank you. Yeah, in talking about transformative change, implementation, the next question, Jessica, I'm sending it over to you and just asking more about the hurdles and the biggest hurdles that in your experience and from your work with Global Fund programs, what were the hurdles that still need to be overcome to help countries make progress towards gender equitable malaria programs?
Thank you very much. I think, we've come a long way since 2016 when we started talking to national malaria programs. I know Valentina was there with me when we had our first discussion with them about populations that were being missed and reinforcing to them that they are doing excellent work, but there are portions of the population that simply are not being not having access to services. So I would say the first thing is understanding where those populations are, as I mentioned before, how you should reach them, with what intervention, do you need to use tools in different languages, and so on. But I think the biggest issue, and I think all of us who work in malaria know this, is that funding is really a very significant issue when it comes to reaching everyone with an intended service. I think COVID, having worked on some of the guidance for countries around mass ITN campaigns and COVID, funding COVID is just adding another layer of funding challenges at the country level. But I think, again, just to reinforce, I think that countries are doing an amazing job, but it's always a good prospect to be better. Thanks.
Awesome. Thank you. And Olivia, if you can just please tell us, how can we empower malaria endemic communities to lead more gender equitable programs themselves? So I know you touched on this earlier, but on the empowerment.
Yeah, so I think the first way to empower this community, they are involved at every level in the process. So empower them means listening to them, means making sure that we do less of the talking and more of the listening. We listen to what they want, we listen to their issues, we listen to their own solutions. And then we also make sure we have a representative of this community included in the spaces where decisions are being made around this malaria program. That's the best way to empower them, is to let them lead and to actually make sure we include their feedback, but meaningfully, when we design interventions for malaria programs. And on top of that, if we can continue to build capacity of local NGOs, of civil society organizations, of community groups around these issues of gender equity, it's going to actually help to empower the whole community around those specific issues. So I think it's really something that the malaria community needs to reinforce very strongly, because it's like we all said, and like we all think it's unacceptable that today we have a disease that we can prevent and we can treat fairly easily, and like COVID-19, malaria we can treat, we can prevent, and we can treat the disease. So there's no reason why we have thousands of deaths due to malaria each year. So yes, it's possible to empower them, and we think that we are moving into the right direction as a global malaria community, but much effort needs to be done to make sure that empowerment and that inclusion is actually meaningful.
Great, thank you. And I'm going to direct the next question to Jessica. And again, you talked about the hurdles and the funding challenges, but despite that, what is being planned to assist countries to ensure equitable access to services and commodities for malaria?
Well, thank you for that follow-on question. I'm happy to say that beginning in 2021, the RBM CRSPC, that's the Country Regional Support Partner Committee, excuse me, and under the CREMA workstream, which is a workstream that I co-chair on resource mobilization and advocacy at the country level, we will be looking based on country needs and requests how to build capacity in this area, and also continuing some of the work that Olivia did in Niger and Nigeria to provide technical assistance to countries to ensure that access, gender, and human rights barriers are understood at the country level and address the utilization of the Matchbox and other relevant tools. And of course, I want to say that, part of this is to really strengthen community engagement through pertinent avenues and organizations such as Unicef and Impact Sante. Thank you.
Thank you. Thank you. I'd just like to thank all our panelists and just hearing about the great work in covering the unique needs, of women, and in this great work in eliminating malaria and all your involvement. So thank you so much.
Yes, thank you so much again. We're at time. I wanted to thank you, Marcia, as well for moderating this lovely panel today. I hope our audience has come away with some of the ways that malaria and gender equity are very interconnected. I would like to encourage any of you who are interested in our past webinars to go to the Malaria Partners International YouTube page. If you want further information, though, about Rotary's efforts to eliminate malaria, please check out our website at malariapartnersinternational.org. And we hope you'll join us again in the future. So thank you, everyone.